I want to talk about facelift now. Now, facelift is a very confusing term because it's used for everything, even sort of figurative things like I'm going to do a facelift for my house. But the word facelift is a lift that occupies the mid-cheek, lower face, jawline, and neck. And so that's what is being lifted. It's a lower face and neck lift, mid-face, lower face, neck lift, things like that. The thing that I don't like are all the marketing terms out there people use to describe lifts that, in my opinion, don't mean very much. They're only meant to sell you something. So people ask me, do you do a V-lift, ponytail lift? Do you do this kind of lift? Do you do endoscopic lift? All these kind of lifts, to me, are just sort of bogus, in my opinion. The area that I don't believe in lifting is really the upper third of the face. Now, the reason for that is very complicated. I'm probably gonna have to do a separate video in describing that, but suffice it to say that even my colleagues that do really good facelifts, I look at their brow lifts, I don't like the look of it. It looks a little startled. I don't believe brows should be that high. I believe in filling the brow with some fat, taking a little extra skin away and reshaping it, but I don't like high brows, okay? So when I'm talking about lifting, I'm talking about the mid-face, lower face, and neck. So that's really when I talk about a facelift. A neck lift is very similar to that. So the facelift that I do is called a deep plane facelift. Why is it called deep plane? So there's levels. So first of all, before I talk about that, I don't do thread lifts. I don't believe in them. I don't think they last. Now, why aren't thread lifts around? 10 years ago, I used to do thread lifts, but they came back on the market because the company decided to sell this again. Now everyone else wants to sell it, but I don't think they work. Why is that? Well, this is the reason why. I'm going to talk about a deep plane facelift because the deep plane is a plane, there's a layer called the SMAS, superficial musculoafferotic system. It's the fascial layer that encompasses all the way down into the neck, and that's the layer that I lift. However, if you in the past, I would just pull this and I'll get more short-lived results. So there's really two types of facelifts. Without describing all the marketing terms, there's a SMAS facelift and there is a deep plane facelift. The difference is the SMAS facelift, you just take those, expose all those deep tissues and you pull them. And the problem with the SMAS facelift, in my opinion, the reason why you can't get really good durable and smooth elevation is that there are ligaments. These ligaments are binding down the tissues from holding up. It's like as if I want to pull on something and you're pulling the opposite direction, preventing me from pulling it up. So a deep plane facelift is something that creates a much more durable, better result. What are these little ligaments that need to be released? The two principal ligaments is this skin ligament called the mandibular ligament here, and that ligament wraps around the chin like this. When I learned in textbook, it goes here. Now, it actually wraps all the way across here under the skin. There is also a posterior retaining ligament that runs down in front of the sternocleidomastoid muscle. Those are the two you must release, in my opinion. Also, protomasseteric, and then there is a zygomatic ligament. These are also important to lift, but not as important those two. I release these four ligaments, and that allows me to have a gentle lift of the tissues that are unrestricted. And so that way I can get a lift of the mid-face, lower face, jawline, and neck. And to me, that's really, really critical. So how do I go about doing this procedure? So I lift, I make the incision underneath the chin. The platysmal muscles, that's the muscle that's sagging here, that is the redundancy. And like this morning, I just did a facelift all the way down to the sternal notch because the sagging muscle is all the way exposed, hanging like this. Why do I have to make the incision here? Why do I have to work in the neck? Here's the reason why. Think of it like a hammock. If I'm just lifting the sides and not the center, I still have this part that's not as good. So what I do is I first tie the center together and then I lift up the sides. All the stitches that I use for a lift are dissolvable stitches. I've fortunately not had an issue with infected deep stitches, but this is why I don't like permanent stitches in the face because there's a risk of an infection even a year out. So I use all dissolvable stitches, but I use a ton of dissolvable stitches. I think I use maybe 10 different stitches. So when I'm working the neck, to minimize the recurrence of this, I put individual stitches all the way down, usually about 15 to 20. Then I come back and I take a running stitch all the way down and up, and another one running down, up and down, and then I take a horizontal one coming down to inverted four. So oftentimes 4 to 5 or 6 layers. It's like a corset where I'm just constantly redundancy. Redundancy is important to get great longevity on this. The other question people have is, where are these incisions you have? So I want to sort of juxtapose my incisions versus the incisions out there. The traditional incision are very long. A lot of hair loss, temples, because I do a lot of hair transplant here, the temples are sitting way back here that look abnormal. This, you can't even wear it up because you've lost all the hair back here when you have an incision going back here that goes low. those are, to me, telltale signs you've had a lift when you can't wear your hair out. So my incision is typically very well camouflaged under the temple, and it's hidden inside the ear, and then on the back side hidden here at a short distance high up here through the point of where the ear bends back, so you can wear your hair up and not be afraid that there's going to be a visible scar there. Of course, for the first 1 or 2 months, it could be more visible, but long term, most of my patients, if you see them, you look up close, you can't even see the incision because it heals so well. The other trick is to thin this flap. So this is an area where I hide the incision inside the ear. Except in men where they want to wear a beard or something, then I may be making an incision slightly different. It goes beyond the whole discussion of what I'm trying to get to here, but I just want to talk about the basic idea is what's called retrotragal, which means I make it inside here, flatten and really make that a thinned out flap so it looks natural, not bulky and thick. The trick is good scar camouflage is whenever I do a scar revision, like let's say someone cut themselves here, is not to make a straight line. I make it zigzag, 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 so you have a hard time seeing it. Well, it's the same thing around the ears. When I go down, I make a zig, a zag, inside here, back, inside, back out, in, out, all along that natural line, but it's also not straight. When it's not straight, your eye has a hard time seeing it. And so that's why, and there's no tension either. And so that's why my incisions typically heal very, very well. Let's talk a little bit about the recovery. Typically, there's not a lot of pain, and the vast majority of my patients have very little bruising. The reason for it is I use a product called tranexamic acid, or TXA. That product helps minimize and virtually eliminate bruising in the vast majority of my patients. So that has been great. I use suction drains. Those are those ugly grenade drains that come out there. I typically take them out the next day. They don't hurt when I take them out. The reason I like those sitting in there is that if you have an easy second week and make it a relatively shorter recovery time, then I think that's the goal. If you have these drains there for even 4 days or 5 days, they're causing a little blood to come out, then that, to me, is worth it if the next week you don't have bruising or very much bruising or swelling. You go back into the workforce or back into your school or go back into whatever life you're trying to lead, social life. So that's why I use these kind of drains. The neck has different types of anatomy. Sometimes there's glands that stick out that I've got to reduce. When I take those glands out, called the submandibular gland, I shave those down in those patients that have a very bulgy outside neck to create a better balance. I leave a drain in for 7 days. That's because there's a risk of a salivary leak or saliva leak. Fortunately, I've really rarely seen that, but that's why that drain leaves in for 7 days. Otherwise, I won't leave it in for 7 days. The drain comes out the backside, so there's no scarring, hides right in the hairline in the backside. So, why perform a lift? What is the age bracket that's reasonable? This last week, I've done a 73-year-old, a 63-year-old, and a 48 or 49-year-old. So there's a huge range of ages. 37-year-old, I think, is too early unless you've had incredibly bad lifestyle and sun damage. But usually for someone in their 40s to 50, it's typically someone that has a lot of sun damage or just really wants a neck to look cleaner. That's the person that I do in the 40s, but it's rare. The vast majority of my patients are in their late 50s, early 60s, but I have some people in their 70s, as long as they're healthy. Some people in their 50s, just depends on how much aging there is there. The question is, what's the earliest time I should do this? Should I do this, super early? The answer is when you have the budget to do it, when you have enough issues to go, you should consider doing it, because this is what's interesting, is that I found that my patients that have a second procedure, that scar tissue that's underneath that I've built up actually creates even a stronger platform for a second lift rather than making the second lift worse. So it's not unreasonable to start earlier with the lift. What I find sometimes is you have to weigh, is it worth the benefit? If you're only 45 and you have very early sagging, I can oftentimes manage that with a little Kybella. Kybella I don't use in the neck, that's a whole different discussion. I don't think it works well in the neck at all. I don't oftentimes even take fat out of the neck because I think it's bad. But I suction out the jowls this morning. I suction this lady's jowls out, and Kybella can reduce the physical presence of the jowls, or I can streamline it with some fillers. So if you're in that early phase, not deciding, should I do a lift or not, really it's going to be a budgetary thing. The recovery is typically not bad. Most patients are not in a lot of discomfort, typically don't have a lot of bruising and swelling, and oftentimes after a week are more or less good to go, but a few patients could last a little longer, 1 to 2 weeks. About 20 to 25% of my patients I'm doing a chin implant in. The reason is if you've got a really short neck, I've got a short neck and I've got a short chin, I would look 10 times better with a chin implant, whether I do a facelift or not, but just a little bit of projection will actually add a pivot point around which I can lift it. And it creates the illusion of a longer neck even before I actually lift it. So that's a whole different discussion. I'm gonna do a video on chin implants as well because I do a ton of those. But that is something that can oftentimes enhance it. Won't change your look. Actually, I'll tell you a story for the lady last week. She just did a video testimonial, 63-year-old lady that said, Dr. Lamb, I don't want a chin implant. I just want to lift. And she's had such a short neck and such a short, very long neck actually, but a very short chin and a very prominent nose. I said, look, you really should consider a chin implant. It'll make such a difference for you. And she finally said, okay, but I just want a medium. I said, you really should consider a large. I'm not here to be pushy, but oftentimes you don't know what you need. So I did the large for her, of course, with her approval. And she said, Dr. Lamb, that was the best thing. I'm so glad I go medium. I'm so glad I didn't skip that implant because I think 50% of the battle, even though I worked so hard to tie those bands all the way down to the sternal notch, all the way across there, half the battle was that chin. And a lot of times people worry they're going to look different or, be weird looking. No, if it's done well, it's really invisible. But that's something I just thought about that I think it was worth just talking about as part of this. So are you a good candidate, not a good candidate? Obviously this video is not going to tell you anything because I haven't seen you. But it's important that I talk to you about this in this video. One other thing I thought about is that a lot of people pull their face back and go, this is what I want. And that really, it's not a skin pull. This morning I had that much extra skin on this woman, but I didn't pull the skin. Because I lifted the deep tissues, the extra skin just follows it. So when you pull the skin, it's not realistic. So this area, the downturned mouth, can oftentimes be helped with the lift, but it may not be completely gone. The fold may be helped with a mid-facelift, but it may not be completely gone. So these are areas that some fillers could help, and especially if someone doesn't want to lift, that definitely can help. But oftentimes it's not even that important when you're looking at the upper fold. So it just depends on the person. But the lift is not equal to just a skin pull. So a lot of people do this, I call it the two-finger rule, because they pull back everything and think this is what equals to a lift. So what is a lift? Well, it is a lot of this lifting across here, but it's not exactly equal to taking your skin and pulling on it. So I look forward to seeing you in consultation and maybe addressing some of these issues more clearly in person.